Hello, um, welcome to another session of Zooming Through ID. I am Dr. Gopal, an infectious disease specialist, trained at Duke University, been practicing in South Florida for a little over 20 years. I'm a faculty for infectious disease at Broward facility. We have a infectious disease fellowship program, and I'm the APD for that. I chair the infection control. I chair infection control, and I'm the medical director. And I chair the antibiotics stewardship for the 4 facilities at Broward. Today, I'm going to talk regarding a very interesting topic, meningitis. So, we will be talking about I'll be talking about bacterial pathogens, the clinical presentation, diagnostic findings, and management principles of strep pneumo, Neisseria meningitis, H. influenza, Listeria MRSA, viral pathogens, enterovirus, HSV2, West Nile virus. We'll talk briefly about the parasitic pathogens, Angiostrongylus, Naegleria, and other parasitic CNS infections, and we'll be talking about some diagnostic pearls. The CSF parameters, they are very important. Bacterial versus viral meningitis. The opening pressure for bacterial will be in the range of 200 to 500. Viral, it will be less than or equal to 250 millimeters of water. WBC count will be 1,000 to 5,000. In viral, it will be less, 50 to 1,000. WBC differential in bacterial meningitis, it will be neutrophilic predominance, viral lymphocytes. The glucose will be less than 40 for bacterial, greater than 45 for viral. CSF to serum glucose will be less than or equal to 0.4 in bacterial, greater than 0.6 in viral. Protein 100 to 500 milligram per deciliter, and viral it will be less than 200. This gram stain is very important. It will be positive in 60 to 90% of cases of bacterial meningitis. For viral, it will be negative. This is very important in clinical practice as well as for your board review questions, because if you see a case of meningitis, there will be CSF findings that they will be showing to you. Epidemiological features. Meningococcal meningitis, there are serogroups A, B, C, W, and Y. There is a predisposition for congenital deficiency in terminal complement deficiency. Risk factors mainly HIV, MSM. For pneumococcal meningitis, there is an association with, it's usually associated with pneumonia, otitis media, mastoiditis, sinusitis. There can be head trauma, CSF leak, rarely endocarditis. Listeria meningitis, they're associated with elderly, alcoholism, malignancy, hepatic or renal disease. There has been outbreaks associated with cheese, coleslaw, ice cream, processed meat, hog head cheese. To summarize, I'm giving 3 scenarios. One is strep pneumo. It will be an example case, a 67-year-old male with history of diabetes and otitis media. The CSF would be turbid. WBC will be 2,840. There will be neutrophilic predominance, 94% PMNs. Gram-positive diplococci in strep pneumo. Complications, seizures, hearing loss, treatment, vancomycin, and third-generation cephalosporin. Neisseria meningitis, a sample case is an 18-year-old with petechial rash. CSF, purulent CSF, WBC 3650, gram-negative diplococci is a finding in the gram stain. Complications include septic shock, DIC. Treatment is third-generation cephalosporin. Listeria, the sample case is a 72-year-old immunocompromised patient, CSF WBC, it is actually less, as you can see, 485. Gram-positive rods. Rhomboencephalitis on MRI can be seen. Treatment is ampicillin or penicillin plus addition of aminoglycosides. So this, we already talked about a comparison of the CSF. There will be markedly reduced CSF glucose and elevated protein in bacterial meningitis. Listeria, often there will be modest CSF abnormalities with mixed pleocytosis. So there can be a diagnostic delay. Question. A 20-year-old male with a VP shunt with headache and fever. CSF culture shows gram-positive rods after 6 days of incubation. What is the most likely organism? A. Listeria. B. Pseudomonas. C. Cutibacterium acne. D. Nocardia asteroides. The answer here is C. Cutibacterium. There has been an association with VP shunt. That's one factor. The second clue in this is gram-positive rod that grew after 6 days of incubation. So it takes time to grow. Some etiologies of bacterial meningitis: Staph aureus, neurosurgery, trauma, alcoholism, diabetes, hemodialysis patients, IVDA, and malignancy. Gram-negative is associated with disseminated strongyloidosis in infection syndrome. That's one other scenario where you will see a gram-negative meningitis, E. coli or any other gram-negative. Staph epidermidis and Cutibacterium association with the CSF shunts and drains. Other scenario where you see gram-negatives is after head trauma, neurosurgical procedures, shunts and drains. Anaerobes, usually from contiguous foci in head and neck. Streptococcus salivarius, there is an association with spinal anesthesia and myelogram. Streptococcus suis in Vietnam, and there is an association with eating undercooked pig intestine or blood and pig exposure. My antimicrobial treatment for strep pneumomeningitis. If the penicillin MIC is less than or equal to 0.06 microgram per ml, penicillin G or ampicillin is the treatment of choice. If penicillin MIC is greater than or equal to 0.12 microgram per ml, and if the ceftriaxone MIC is less than 1, third generation cephalosporin is the treatment of choice. If ceftriaxone MIC is greater than or equal to 1, then vancomycin and third generation cephalosporin. If ceftriaxone MIC is greater than 4, consideration of addition of rifampin. For Neisseria meningitis, if penicillin MIC is less than 0.1, penicillin G or ampicillin. If penicillin MIC is 0.1 to 1, then third generation cephalosporin. In clinical scenario, we usually use third generation cephalosporin. For H influenza, if it is beta-lactamase positive, third generation cephalosporin. If the H influenza is beta-lactamase negative, you can use ampicillin. For Pseudomonas, ceftazidime or cefepime or meropenem. For MSSA, nafcillin or oxacillin. For MRSA, vancomycin. For listeria, I already told you ampicillin or penicillin. We have to consider addition of aminoglycosides. Strep egalactiae, ampicillin or penicillin G. Acinetobacter baumannii, its treatment is mirum or colistin. Also, there is a need to give intrathecal or intraventricular colistin. The use of dexamethasone in bacterial meningitis. So what it does is it attenuates the subarachnoid space inflammatory response resulting from antimicrobial induced lysis. The recommended dosing for pneumococcal meningitis is 0.15 milligram per kilogram IV every 6 hours for 4 days. It's also recommended for infants and children with H. influenza type B meningitis, and there is a consideration for pneumococcal meningitis. Next question. A 35-year-old male with history of splenectomy presents with fever, headache, and altered mental status. Blood culture is positive for encapsulated gram-negative diplococci. What is the most appropriate prophylaxis for close contact? A. Ceftriaxone 250 milligram IM once. B. Rifampin 600 milligram POQ 12 hours times 2 days. C. Ciprofloxacin 500 milligram PO once. D. Any of the above. So the answer is any of the above. So these are all the recommended regimens for prophylaxis, chemoprophylaxis. Next, we will talk about virus, enterovirus, 8-year-old boy with severe headache and fever, clinical presentation. There will be associated fever, nausea, and vomiting. Preceding sore throat and fatigue for 4 days. School outbreak pattern is typical for enteroviruses. And there is a seasonality, August presentation, summer or fall presentation, photophobia, nuchal rigidity can be seen on exam. Diagnostic findings, CSF 320 with lymphocytic predominance. Initially, there can be a neutrophil shift evolving to lymphocyte. You will see a positive CSF PCR for enterovirus, and bacterial cultures will be negative. Management is usually we will start on empiric antibiotics, ceftriaxone, vancomycin, pending cultures, and then antibiotics are discontinued once you get the PCR and negative bacterial cultures. There is no specific antiviral treatment, just supportive care, IV hydration. You can give acetaminophen for fever, and then you can support with anti-nausea medications, and then usually there is improvement in over 4 days, full recovery within a week, and there is no neurological sequelae. HSV meningitis, it's a case where this is a case where 28-year-old female with recurrent meningitis episode. The first episode, we only see the CSF pleocytosis. The HSV PCR was not sent. Then the patient is coming back again. The HSV PCR was sent, it is positive, and the patient was treated with antivirals. Then again getting admitted, there is a third episode, and there is one aspect to it that we don't usually do the viral copies, but in certain other institutions they do, and then you see a decreasing viral load. So this syndrome, the recurrent meningitis from HSV2, is called Mollaret syndrome. The key features, there is recurrent episodes. HSV2 is a predominating causating agent, and there is an association with genital herpes outbreak. Decreasing viral load with recurrent episode, and CSF shows lymphocytic pleocytosis, and usually these are self-limited, but there is a tendency to recur. Treatment is acyclovir 10 milligram per kilogram IV Q8 hours, followed by oral val acyclovir. One point is chronic suppression with val acyclovir is not indicated. There is an association with higher frequency of meningitis after cessation of active drug. West Nile virus, West Nile virus. So this is a 65-year-old male during one of the summer outbreak. Usually that's a peak mosquito season, July. There's extensive outdoor exposure during that time, and sometimes health department they send out alerts. So the clinical presentation: 4-day history of fever, severe headache, progressive bilateral lower extremity weakness, unsteady gait, and then there is diminished reflexes in the legs, nuchal rigidity, and patient is not oriented, and there can be lethargy. There's no specific antiviral treatment, supportive care, IV hydration, and then there is a phase for rehabilitation phase, and then there people usually have some residual weakness. Elderly patients often have permanent sequelae. So the comparison between the three types of viral meningitis we talked about, as we discussed, for enterovirus, the age group is children. For HSV2, young adults. West Nile, it can be elderly. Seasonality, enterovirus, summer and fall. HSV2, you see it year around. West Nile, summer, early fall. Neutrophilic predominance initially for enterovirus, subsequently changes to lymphocytic, but HSV2 is lymphocytic predominance. For West Nile, it can be mixed pleocytosis. The diagnostic test is for the enterovirus, it is CSF PCR. HSV2, again, there is PCR test. For West Nile, serum and CSF IgM. PCR is often negative. Treatment for enterovirus, only supportive care. For HSV2, acyclovir and val acyclovir. West Nile, only supportive care. And as we discussed, enterovirus, excellent full recovery. HSV2, there can be recurrent episodes, but they are usually responsive to treatment. For West Nile, it's guarded prognosis, often with sequelae. This is a rare form of meningitis. It's lymphocytic choriomeningitis virus. It's a rarely reported as an etiological agent. It is a zoonosis caused by rodent-borne arena virus. So this is excreted in the urine and feces of rodents, hamsters, rats, or mice, transmitted to humans by contact with rodents, either direct contact or aerosol or contaminated environmental surfaces. It's common in winter months. The risk groups are pet owners, lab workers, persons living in unhygienic places. There is no evidence of human-to-human transmission, and diagnosis serology, and there is no antiviral treatment. So some other etiologies, viral etiologies, mumps virus, HIV is other virus. There are many arboviruses. Adenovirus can cause viral meningitis, parainfluenza type 2 and 3. With echovirus, there can be a maculopapular rash. That's an association. Herpangina, that is Coxsackie virus A. With Coxsackie virus B, you see pericarditis and pleuritis. Rhomboencephalitis, there is an association with enterovirus 71. And there is an entity, chronic enteroviral meningoencephalitis, and you see that with A gamma globulinemia. So parasitic presentations, Angiostrongylus cantonensis. This is a eosinophilic meningitis following raw food consumption there are certain endemic areas: Thailand, Malaysia, southern Vietnam, Pacific Islands. It's a rat lung worm. Eggs are excreted in the environment and ingestion of larvae in snails and slugs. The key feature is CSF finding. There will be eosinophils. 10% eosinophils will be seen. Treatment, corticosteroids is preferred over albendazole. Naegleria fowleri, this is a rapidly fatal condition, and it's after freshwater exposure. There are very few cases in the literature and in real cases, very few cases. Exposures are usually lakes, ponds, rivers, streams, hot springs, and unchlorinated swimming pools. So that will be the risk factor, and in both questions that they will definitely mention that. The diagnosis is by motile trophozoites on wet mound in the CSF. There is a PCR test to identify the DNA. Treatment is, there are many agents, amphotericin B, including there is miltefosine, and there are many other adjuvant agents. You kind of throw in a lot of medication because this condition, the mortality is 97% mortality despite therapy. Neurocysticercosis, it is the most common cause of seizures in adults from endemic areas, Latin America, transmitted by eggs from tapeworm, but not through the pork ingestion. There are several forms of neurocysticercosis: parenchymal, subarachnoid, intraventricular, spinal, and ocular. There can be multiple cystic lesions in various stages, and there is a pathognomic finding in the MRI. Treatment, albendazole with corticosteroids to minimize inflammatory response of dying parasites. So let's talk about a case, a 52-year-old woman with relapsing remitting multiple sclerosis that was diagnosed in 2016 on natalizumab therapy since January 2019. JC virus is positive. There is no history of HIV, malignancy, or other immunosuppression. Patient presents with progressive weakness and cognitive decline over 6 weeks. Right hemiparesis worsening over time. There's a new visual field defect, left homonymous hemianopsia. There are personality changes and apathy noticed by the family. So this is a timeline of disease progression. Week 1, there is initial word finding difficulties and mild right-sided weakness. Week 2, personality changes become apparent and there is withdrawal. By week 4, there is development of visual field defects, progressive worsening of right-sided weakness. By week 6, there is significant cognitive impairment and requires assistance with daily living. The exam findings, the patient is disoriented to time and place. The MMME score is 18. There is impaired memory and executive function. There is right hemiparesis, hyperreflexia on the right side, and positive Babinski sign. Cranial nerves, right-sided facial weakness, and left homonymous hemianopsia, sensory function abnormalities, decreased sensation on the right side, and intact proprioception. So this is a condition, the PML, associated with natalizumab treated patients. So lab findings, basically the lymphocytes will be lymphocytic count about 800. The CD4 count is low normal, 420. And the CSF WBC is 8, lymphocytic predominance. And protein 55, the JC virus is positive. That is the key. And bacterial and other viral PCR, bacterial cultures are negative, viral PCR negative. So this is a case of PML. And there are classic MRI findings. Large, T2 hyperintense lesion in the left parieto-occipital white matter with finger-like extensions, characteristic of PML. So to summarize, meningitis is a very important topic that you will definitely be seeing in clinical practice as well as in the board question. And hope this presentation helped you to formulate some of the ideas. Some of the points that I didn't mention, one is if somebody is allergic to penicillin and if they have listeria, Bactrim should be the treatment. If you see a splenectomy patient, strep pneumo, you have to be thinking about that. In the board question, they may not say splenectomy, but they may say that the patient had staging laparotomy, or they may say they saw, there will be Havel-Jolly bodies in the peripheral smear, so that those are clues for the splenectomy. Some of the other risk factors, the terminal complement deficiency and Neisseria meningitidis, that is an important risk factor to consider. If you have, there are certain other clues and words like St. Louis encephalitis. Patients will have hematuria. That is one clue. Not all CSF picture that they show may be due to infectious causes. Aseptic meningitis can be due to other drugs. You have to be thinking about Bactrim can cause that, NSAIDs can cause that. INH can also cause that. And then it can be non-infectious or not drugs. It can be due to collagen vascular diseases, sarcoidosis, or malignancy. So those are all other differential when you see that type of a CSF picture. So I think that concludes my presentation, and hope you all enjoyed it. See you all at the hospital. Bye.